All right. We'll start with basic cardiac physiology for this video, which includes looking at a knowledge of basic cardiac anatomy and function, basic knowledge of the physics of pump physiology, and the relationship with the peripheral circuitry, which is the paramount relationship to understand in the cardiovascular system. Essentially what you have is that the pump and the circulatory model has two systems which interact dynamically. You have right heart circulation and output to the pulmonary circuit, and left heart circulation and output to the systemic circuit. We can understand this system by thinking about resistance and capacitance. One of the most important things to remember in the cardiovascular system, however, is that the driver of cardiac output is tissue metabolic demands, or the oxygen demand of the body. So assuming that the system is a closed system with a stable volume and transitional states of resistance and capacitance, this means that our right heart output is always going to be equal to the left heart output. Capacitance and resistance in the peripheral circulation is going to be controlled by metabolic demands and is dynamic. A person sitting at rest is going to have less oxygen demand than a person who is exercising, for example. Resistance occurs in our larger vessels, and capacitance occurs in our smaller vessels. If you think about the smaller vessels as the large network of arterioles and venules, makes sense that that's where there's lots of surface area, and so we have capacitance, whereas resistance is going to be in our larger vessels as they travel through the body. Since cardiac output is directly linked to tissue demand, a mixed venous saturation, or SVO2, can be used to assess the whole body relationship between oxygen uptake and oxygen delivery. This can be very important in monitoring a critically ill patient. When thinking about SVO2, or your mixed venous sats, there are four conditions that typically can cause this to decrease. Number one is hypoxemia, which is a decrease in your oxygen saturation. Number two is an increase in VO2, or your oxygen consumption. Number three is a decrease in cardiac output. And number four is a decrease in your hemoglobin concentration. This one is often forgotten about, especially in critically ill patients. It can be very important in patients with cardiac compromise, congenital heart disease, or trauma where there's been blood loss. You can see with the relationship of this equation where these different components plug in. This number 1.39 is the number of oxygen molecules per every hemoglobin in the body. The reason this is important is that the system has limited ability to compensate. Typically, when the body is working properly, oxygen uptake and oxygen delivery are balanced. And you can see that there's a certain amount of interplay where small changes will be adjusted for. And we consider oxygen delivery and uptake to be independent of oxygen delivery. However, there comes a point in the system where you have a critical oxygen delivery value, at which point after the curve falls off sharply and the oxygen uptake of the tissues becomes dependent on the ability of the system to deliver oxygen to the tissues, such as a decrease in SaO2 in respiratory distress, and the tissues continuing to need uptake, you can have global desaturation and end organ failure because your O2 sat is not able to, your cardiac component cannot compensate for the loss in saturation of oxygen. So for our pump system, we have a two-system model, and we discuss it as systolic and diastolic mechanics. Systolic mechanics and function are the contraction of the heart to pump blood into the two circuits, the pulmonary circuit and the systemic circuit. The diastolic component is the filling of the heart, which occurs with two components. One is the active relaxation, and two is the passive stiffness of the myocardium. Systolic function has four primary determinants. The first is preload. Preload is the initial volume of the left ventricle prior to ejection. The next is afterload. Afterload is the combined resistance to ejection of blood by the heart, the blood inertia, and the impedance of the central vasculature and the resistance of the peripheral microvasculature. So our resistance components are the force required to eject, the central vasculature resistance, and the peripheral microvasculature. The next determinant of systolic function is our heart rate. And the fourth component of systolic function is contractility. Which is the intrinsic ability of the myocyte to contract.